Thank you, organizers, for having me here. So, my country, Georgia, small country with population of 3.5 million in Eastern Europe, started HCV elimination program in 2015. So it's been 10 years already. So the elimination program offers free screening and diagnostics for HCV and treatment with DAA. So everything's free for people. There were 2 surveys evaluating prevalence of hepatitis C, and the last one in 2021 showed that after 5 years of elimination program, we have 67% decrease from 5.4% RNA positivity to 1.8%. So it's a very good decrease, but still we have way to go until elimination. So Georgia has one of the highest prevalence of injection drug use. Now we have estimated 51,000 PWID. So this means that among adult population, the prevalence of injection drug use is 2.2%. So IBBS, the last one, conducted in 2022, found that 80% of PWID were HCV RNA positive. So this means that we need to improve linkage to treatment. So out of this, by the way, some of them were treated and SVR was reached, so reinfection was 13%. Okay. So our study aimed to improve HCV linkage to care among PWID through pilot peer-driven intervention. Before intervention started, we made some survey to understand barriers of linkage to care. So the previous survey was done in 2018. We used pretty much the same questionnaire. We had 2 groups. One group was lost to follow-up. This means having positive antibody test and never tested for RNA or core antigen, or RNA or core antigen positive but never started treatment. And group 2, control group, who initiated treatment. So as we see in the results, people who never initiated treatment did not consider HCV treatment as important as those who started treatment. And also, people who did not start treatment said that they needed more information regarding enrollment steps. That's a huge problem in my country. People get screening and testing, and many times they don't know what does this mean, what to do next. So post-test counseling is in very bad shape. And even there are people who never know that they are positive. For example, in clinic, hospitals, people get testing together with a lot of tests. They test positive and nobody bothers to tell them test results or explain what to do next. What does this mean, antibody, RNA, and so on. And unfortunately, I'm in clinical practice, so I see a lot of people with decompensated cirrhosis who we see in the database that were screened positive years ago, and they never knew that they had hepatitis. So this should be improved, of course. So peer education intervention was implemented May 2023, February 2024. So 2 harm reduction sites were enrolled, and we recruited 5 peer educators, former or current PWID, who completed DAA treatment, and they were trained to promote HCV diagnosis and treatment amongst their peers. They had very intensive training about hepatitis C, transmission, clinical course, and we tried to develop skills among them, how to counsel their peers. So these peer educators were trained and to target those who are positive, antibody positive, and no HCV RNA testing was done at least 3 months post-screening, or those who had detectable RNA but never initiated treatment. These were their targets. So these peer educators were providing promotional messages regarding importance of treatment and describing their own treatment experience. Well, as in all other countries, in Georgia too, there are a lot of misconceptions about HCV treatment. And in addition, financial incentive was offered to the recruited PWID upon initiating treatment. So the initial amount of incentive was $15, which did not work quite well. At the next stage, we increased the incentive until $40, which enhanced enrollment rates. And peer educators also received some very small incentive, $10, for each successful referral, defined as an individual who underwent HCV RNA testing or initiated treatment with DAAs. So the data about each referred individual was extracted from Hepatitis C state elimination program. Here's results. They reached 55 antibody positive and lost to follow-up PWID. Among them, 60% was HCV RNA positive. All of them started and finished treatment. And they also reached 46 of those who had HCV RNA positive and never initiated treatment, and all of them started treatment. So in total, 5 peers reached 79 PWID, and they were all linked to treatment. As I mentioned, so financial incentive was $15 first, and it resulted in enrollment of 1.9% per month. And when we increased the incentive, it increased 2.5 times enrollment rate, 4.2 persons per month. So our evaluation shows that when peer support is combined with some financial incentives, confirmatory testing and treatment initiation can be achieved. So we are in the stage when we have a hard time of finding and covering new people. At the beginning of the program, we had lines next to clinics. Everybody wanted to start treatment. But now the part of the infected population which never showed up or started screening and never initiated treatment, it's hardest part to reach. And now we are at the stage when we are trying our best to do some small pilot interventions and find those people and get them into the program. So peer-centered model with small financial incentives effectively addressed several gaps in HCV care among PWID in Georgia and re-engaged individuals lost to follow-up. So this is our study team, and thanks to all of them, and thank you for your attention.